So the first lecture is going to be by me, and it's titled Early Access to Primary Palliative Care in the Emergency Department, Exploring the Big Why. In terms of conflicts of interest, I have no formal conflicts of interest to declare related to this lecture, but I do have some financial disclosures related to research, some funding I've received from the NIH, John A. Hartford Foundation, West Health Institute. I'm also a volunteered board of director for Compassion and Choices, which is the country's largest nonprofit organization, which advocates for improved end of life care and rights. So let's just start it right out. The big why. And you may ask, why did I start lecture? Why did I title this lecture The Big Why? Because what I found in my experience as both an educator and an administrator is that when you talk about incorporating palliative care into our clinical practices, you're talking about a culture change. You're talking about a practice change. And in adult learners and really experienced emergency medicine teams or clinicians, and even new emergency medicine clinicians, in order to create practice change, people need to feel the why. They need to understand why this is important. Why am I going to take the time to incorporate this into my practice? So I'm going to spend about 10 minutes really kind of honing in the why. It should be no surprise to any of us in emergency medicine that our specialty clearly lives at the intersection of critical care and end of life. We are the primary portal of hospital admissions, and we're really the primarily portal of hospital end of life care. What I was really impressed by is this study by Elmer et al. In 2022. They do a large retrospective review of deaths in America. And I know that the ED intersects with death. You can't practice emergency medicine and not know that. But what I didn't realize was how significantly we intersect with death in America. Essentially, what Elmer found was that 11.3%, or 1 in 10 of all American deaths, occur in our emergency departments. That means that we have to have the skills, not only for resuscitation and life saving, but everything that comes with the bereavement and delivering death notifications and all the complexities that come with dealing with death in the ED. What Elmer et al. Found as well in this article, which I was really impressed with, was that a third of all American deaths visited the ED with at least once within a month of their death. And what that shows us is that there is a window of opportunity for us in EM to maybe identify this group earlier and help them. These are just statistics. And again, I think we're well aware of this. Our older adult population, age over 60 or 65, they are the highest ED utilization group compared to any other age cohort. And in fact, that age group, half of them will visit the ED as well within the last month of their life. Again, showing us that there is this window of opportunity to maybe identify people who are nearing the end of life earlier and provide them some support services that aren't typical of what emergency medicine was originally developed around. This slide, and I apologize because it's not politically correct, but it's actually like from an image and a sense of what's happening is very accurate. And what it describes is the aging population that's occurring, the trends that are occurring within the United States and around the world. And it's described as the gray tsunami or the silver tsunami. And specifically, what it represents is that by 2030, all of the baby boomers will be 65 or older. We'll have more patients within the age range of 70s and 80s and 90s than we've ever had in the history of the United States. And that group is going to develop chronic and acute conditions that have great complexity. And when this tsunami lands and this healthcare needs to be provided, it will land in our American emergency departments. We're seeing it already. We're already providing this complex care, but we're going to need to get good at it. And we're going to need to refine our playbook. And I'll talk about that more as well in a moment. So, what is our playbook right now? Emergency medicine very much was founded around a resuscitate first paradigm. And that makes complete sense, right? Emergency departments were developed for, trauma and cardiac arrests and strokes and acute life-threatening conditions. What emergency medicine has morphed into in 2025 is different from where it came from. And in the resuscitate first paradigm, that's kind of our comfort zone as EM physicians. It's the ACLS, it's the airway, breathing, circulations. Let's activate the code team. And we go through our processes. But what happens in the resuscitate first paradigm, unfortunately, is you're having a group of patients with really chronic conditions, already poor level quality of life or high morbidity, and they present with acute decompensations. And then we just go through like our process. We intubate them, we press them. If they lose pulses, we start CPR. We do diagnostics and we dispo. Where do we dispo? To the hospital or ICU. Often these patients, when they leave the ED, if you asked us, would you be surprised if this patient would die on this admission? We would say, no, I'm actually expecting them to die. But we admit them to the hospital and they linger within the hospital on vents, develop iatrogenic complications like healthcare associated pneumonias. They go to the OR for ischemic bowel. On day 7, day 8, they develop shock, MODS, cardiac arrest. And then suddenly we get hospice and palliative involved, and they essentially go through that process of goals of care conversation, withdrawal of care, and the patient dies on hospice or palliative care within hours, when in fact that's probably too late. So what is the reconceptualization look like? The reconceptualization of early EM and integrating palliative care into our practice, it looks more like this. These patients come in, as I described, around acute and disease targeted care. They're ill. But we, as emergency physicians, we initiate our initial assessment and resuscitation, but we pause. We take a moment to identify, hey, is this patient have a good prognosis? Do they have unmet palliative care needs? We take a moment somewhere in our ED care to sit down for 5 minutes, and we'll teach you guys how one day in this series how to do a 5-minute goals of care conversation. And very quickly you can connect with the patient and the family, and you can start getting information and find out what the patient's true goals are. You can confirm their code status. If their goals are more toward comfort or palliative, we can consult hospice and palliative from the ED. If their care is more resuscitation and aggressive care, that's fine. But as long as we're kind of sorting them out, we'll have much less late hospice entry on day 8. But these discussions can happen earlier. And I tell you, I have these discussions with my patients and families in the ED, and they're not ready for it. But then my ICU counterparts have it the next day or the day after. And these patients will say, you know what, Dr. Ganaga told us this in the ER. We weren't ready, but we're ready to have this now. And so these are our opportunities. And this is the reconceptualization and integration of palliative into EM. I want to quickly introduce a couple basic definitions and terminology that I want us all to feel comfortable with while I'm talking and while Karen is talking in her next lecture. But what we're talking about specifically is this cohort of palliative and hospice care. But what we can do in the emergency department and that we can be masters of is what is called primary palliative care. And primary palliative care can be provided by any type of clinician, physicians, nurses, paramedics, social workers, chaplains, and it all is kind of involved around having discussions around goals of care, trying to focus around comfort, identifying needs, and then trying to get our specialist palliative care team, the people that do this day in, day out, let's get them involved earlier. These are specifically our hospice and palliative, boarded or life trained, physicians and clinicians. That's our specialist palliative care team. Hospice, though, specifically, and this is a very rudimentary definition, but it lives under the umbrella of palliative care. And in a lot of ways, it is essentially a palliative care program that is specifically designed to provide specialized care for patients who have been estimated to have a prognosis of 6 months or less, and who have chosen to move away from disease targeted care and are really looking for comfort care at the end of their life. So I want to make sure those three definitions are kind of out there because we're going to use these words a lot today and in the future. All right, so good news. It'd be almost impossible for Ganaga or Jabadnik or the SAM Palliative Interest Group to kind of change practice in EM, but we don't have to. Our own college, the American College of Emergency Physicians, back in 2013, identified early access to hospice and palliative care in the ED as a top three priority in their Choosing Wisely campaign. Very next year in 2014, the Geriatric Emergency Department guidelines, 42 specific recommendations around five big, core categories, but they identified two specific recommendations around early initiation or the capability for EDs to be able to provide palliative care consultations in the ED. And then in 2021, Lafredo et al., they published this beautiful best practice guidelines for primary palliative care in the emergency department. They really outlined a wide variety of research and opportunities, and they specifically identified in the end that essentially best practice for us in emergency medicine is to have processes in which we are screening for patients who may benefit from early palliative or hospice resources, that we get really good at managing complex pain and symptom management, in cancer patients and patients who are on chronic opiates. How do we manage that group of pain and symptoms? We got to start getting better at goals of care conversations. We got to address code status early whenever possible. And when we identify the patients and the families who will benefit, we need to consult our hospice and palliative, colleagues. Look, we're no stranger to consulting people in the ED. We consult cardiology, neurology, trauma, surgery, optho, you name it. But you got to stop and think, where do you start adding palliative into your consults and into your armamentarium while you're caring for patients in the ED? The other good news here is there is a growing group of literature, strong literature, that is supporting these practice recommendations. My colleague, Dr. Jabaniak, is one of the co-authors of this paper, as well as a bunch of my colleagues on the Palliative Medicine Interest Group. But specifically, between the last 30 years, decade by decade, we are seeing almost exponential growth of research and publications around this space. You can see in the 90s, there was only 100 publications. 2000, the first decade, almost 500. And the last decade, it's almost 2,000. Already just in 2020, and at that time, it had almost eclipsed the decade earlier. So we're going to see growing literature and recommendations around this. And, as the evidence will hopefully support, we'll learn how to implement this into our practice. I'm going to start to wrap up here, but I want to show a figure here from my colleague, Dr. Naomi George, Dr. Jason Bowman, Aaron Aronson, and Dr. Kay Auchi. But they wrote a beautiful paper called The Past, Present, and Future of Palliative Care and Emergency Medicine. And in that paper, they propose that in our current state, that essentially for every 100 patients with serious life-limiting illness, maybe only about 2 patients get access to palliative care, whereas the other 98% are getting usual life-saving or resuscitate first type of care. They propose that over the next decade or two, with continued research, training, lectures like this, webinars and toolkits like we're hoping to create, that we'll start to see a culture change within emergency medicine, in which, maybe only about 3 patients are getting formal hospice palliative consults in the ED, but about 40% are getting some type of primary palliative care from us, that we're screening them, we're trying to consult earlier. And then those who wouldn't benefit from early palliative or don't want it will again get continued high quality life-saving care. So that's kind of the vision. My research team within Henry Ford has kind of looked at this, and I just want to share you some 7-year trend data within my health system. So I collected data for 7 years between 2016 and 2022. Dr. Buckheister was on this webinar, co-author with me on this work. But we essentially went from 2016 to 2022, looked at all the hospice and palliative care consults ordered in our EDs, and there are 5 EDs in our health system. In 2016, between all 5 EDs, we only had 324 ED initiated consults. But what you can see is year in, year out, we're increasing the number of consults from our EDs. By 2020, when, COVID came, we had already reached 1,000 consults a year from our EDs. COVID amplified, I think, the role of hospice and palliative for patients, and you can see that trend continues. What's really interesting is, okay, you say, hey, we're seeing a trend. What's the benefit? Well, here's where the benefit lives within our health system. This is a group of about 45,000 patients who received hospice palliative care consults. This first group here is a group that received consults in the ED. It's about 6,000 patients. This last group here is a group that received consults after 48 hours of being hospitalized. And what you see is if you got a consult in the ED, there was a 16% overall reduction chance that you died in the hospital. This group still died, but they probably died at home or a setting of their own choice. Also, this group in the ED spent 4 less days in the ICU than the group that got late consults. So you can see where there's a benefit. So I'm just going to wrap up here, but what's the big why, guys? The big why is that as you learn to incorporate primary palliative care skills into your practice, you will be promoting patient-centered, goal-aligned, or goal-concordant care. And that's really important, that what the care we're providing for our patients and families is actually the care they want. When you do this, you will form a connection with patients and families. It improves patient, family, and clinician satisfaction because we've all kind of had our existential moments when we're doing CPR on a 90-year-old nonverbal patient with dementia and wondering when after we got Roski, what did we do, So there's an opportunity here for like wellness even within our own specialty. There's a value-based care argument, that we're going to reduce hospital ICU days, healthcare expenses, and that's valuable to the patients and to health systems. And then ultimately, though, when you get really good at these techniques, you're hoping for more quality days at home. So I'm going to leave it at that. And I just want to make one more plug. If this is a topic you're passionate about, if you liked what Karen and I in this webinar is discussing, please come join our palliative medicine interest group.